So I'll be talking about VA ECMO. VA ECMO basically, as we have discussed already, it provides both cardiac and respiratory support, and it buys you time for your heart to recover. So that is the crux of it. So whenever you decide to put your patient on ECMO, this is a decision algorithm which you should have in your mind. As Dr. Vajeesh also said, that first optimize your conventional therapy, see if it has worked or not. If it has not worked, see if there's any contraindication to ECMO. If not, then consider if this condition is recoverable or not. Very, very important. Only if it is recoverable, then you can put ECMO as a bridge to recovery. If it is not a recoverable condition, the next thing to be sure that the candidate is a candidate for some destination therapy, either a lung transplant or a heart transplant. In case of VA ECMO, yes, a candidate is a candidate for a destination therapy, then you can put VA ECMO as a bridge to destination. So as Dr. Vajeesh also said, that there are only two destinations. It's either recovery or a proper destination where the patient is getting transplant. So these are the only two ways a patient can actually move from ECMO. So we have already spoken about the indications and contraindications roughly. So the only key thing to keep in mind is that the condition is recoverable. Or if not recoverable, then obviously the patient has some destination therapy. So these are the basic indications. Any cause of cardiogenic shock, most commonly like ACS or septic cardiomyopathy, peripartum cardiomyopathy, drug overdose. We have put a lot of patients on of drug overdose on VA ECMO, including tricyclic antidepressant poisoning, calcium channel blocker poisoning, and beta blocker poisoning. These three I've personally experienced putting them on VA ECMO when nothing actually worked. Then, of course, pulmonary embolism. In COVID, we did put a patient on VA ECMO after he arrested from a massive PE, and he was eventually put on RVAD, and then he is on list for transplant in Wythenshawe, which is Manchester's sister unit for ECMO. And also then we have cardiac trauma, which is a cause, acute anaphylaxis and acute indication. Very commonly, if the patient is undergoing cardiac surgery and not able to be weaned off from CP bypass, as Ansari said earlier, also post cardiac transplant patient, if you did a cardiac transplant and it didn't work. So these are the usual indications for VA ECMO. Again, contraindications, I will not go through the long list. The crux is the same. Look at the frailty score, look at the background of the patient, look at the recoverability of the condition, look at all these things and make a call. So basically, any malignancy, any unrecoverable heart, any prolonged CPR or unwitnessed cardiac arrest, or unrepaired aortic dissection, severe AR, all these things are actually not indications to put somebody on ECMO. So these are very common contraindications of VA ECMO. I have not used the score or not worked in a place which uses the score, but ELSO does mention this safe score for VA ECMO. No need to mug it up or anything. You can look at it and on QMD Cal and find the score and just do the scoring and see if your patient is eligible for ECMO. Personally, I don't have an experience to tell if the score works or not, but I think it is presumably the sister of RESP and the Murray score being used for VV ECMO. So this is how your configuration for VA ECMO goes. It is pretty similar to VV ECMO. It's only that the return cannula is going into the arterial system instead of the venous system, because you have to support the heart also along with lungs. That's the major difference, isn't it? So this is the basic systemic configuration of VA ECMO. So similar to what Dr. Vajeesh has spoken till now, except that this part is going into the arterial system instead of the venous system. So this is just a better diagram to show you how we cannulate the femoral artery and the femoral vein. We usually don't do it on the same side, contrast to what it is shown in this diagram. And then from the drainage cannula, it goes into the pump, and from that to the oxygenator and return to the heart. So this is the basic configuration of the VA ECMO. So basic differences, okay, so this is important. Like VA ECMO provides cardiac support also, and VV ECMO is not able to do that. VA ECMO requires arterial and venous cannulation, obviously, and VV is only venous cannulation. VA ECMO bypasses the pulmonary circulation or decreases the pulmonary artery pressures, but VV ECMO maintains pulmonary blood flow. VA ECMO can be used in RV failure, but VV can't be used. In VA ECMO, lower perfusion rates are needed, and in VV ECMO, higher perfusion rates are needed. Higher PaO2 is achieved in VA ECMO, and lower PO2 is achieved in VV ECMO. So, and in ECMO circuit is connected in parallel to the heart and lungs in VA ECMO, and it is connected to series to heart and lungs in VV ECMO. So, some basic differences. Just a picture to show what is central cannulation and peripheral cannulation. We will talk about it in a little bit of detail also. So components of VA ECMO and VV are pretty similar, like we discussed, isn't it? Like the outflow cannula is going into the artery instead of the vein to provide circulatory support also. So cannulation for VA can be either central or peripheral. So when it is central, the venous is actually placed in the RA and the outflow is placed in the ascending aorta. And primarily, where is the central cannulation used? So the central cannulation is mainly used in those patients who are not able to get weaned off from the cardiopulmonary bypass. So basically what is happening is that post these cardiotomy patients, for any reason, if they're not able to get weaned from CP bypass, the advantage comes that you already have the arterial and the venous cannulas in place. So you can just start the patient on VA ECMO. You don't have to put additional cannulas at this moment. Central cannulation per se has a lot of disadvantages. Okay, like first, it increases the risk of bleeding and infection because it's you have to re-enter the chest. It is not easy to extubate the patient on central cannulation, and also there is the limit to mobilize the patient is actually very much restricted in central cannulation as compared to peripheral cannulation. So peripheral cannulation is mainly used for cardiogenic shock and cardiac arrest patients, where the venous cannula is there in the femoral vein or the right IJV, and the arterial cannula is there in the femoral artery, or you can graft it into the right subclavian or the axillary artery. So peripheral cannulation is definitely easier as compared to central cannulation. It is quicker also, and mobilization of the patient is easier. There's chances of bleeding, infection, all that is lesser in peripheral cannulation. So this is what we used to do in St. Thomas for VA ECMO. So 21 to 25 French multi-stage cannula into the femoral vein, which was your axis or the drainage cannula, with the tip entering into the RA. And 15 to 17 French return cannula was inserted into the femoral artery, okay, of alternate limb. And 7 to 8 French super arrow flex cannula as a backflow cannula was inserted distally in the same limb as a return cannula. So the main advantage of peripheral cannula was the ease and speed at which you can actually immediately implement the support and outside the operating room. You need not be in the operating room. It can be the ER or it can be, your ICU, where actually you're doing a quick peripheral cannulation for VA ECMO. So cannula size was actually determined on the estimated flow rate. This was a table which we used. I don't think we need to go into the details of that. So starting on VA ECMO, immediately to start, you connect the circuit to the cannula like you do for VV also. Then you immediately ensure that the oxygen is connected and the 1:1 blood flow to gas flow is there. The aim is to actually provide at least partial cardiac support. And what do we mean by that? At least 70 to 80% of the predicted cardiac output, to ensure that there is some flow through the pulmonary circulation also. And aim for some ejection fraction. Some like at least 10 to 20 millimeters of pulse pressure if possible. Then establish your anticoagulation with heparin. Dr. Varghese has already gone through that, so I'll not go in detail. And then ventilatory settings have to be reduced in order to prevent local alkalosis, aiming for adequate PEEP to prevent lung collapse, and mimic ventilation to give an end-tidal CO2 of 2.5 to 3. That will be around 30 to 35 millimeters of mercury, I think. So all patients on VA ECMO, when you are putting the patient on VA ECMO, daily echocardiography to evaluate the cardiac output, ejection fraction, aortic VTI is very important. Right radial and brachial arterial line. I'll tell you why right radial and brachial arterial line. Then we used to have MDT decisions, that is your multidisciplinary team meetings. We used to have. Now you can have it, whenever you want, but we had a protocol of having it on day 3, 7, and 10, and where we used to sit together and see that where are these patients going? Are they recovering? Or do they are they in the transplant list? Or do they need any other ventricular assist device if they're not improving? Or if none of these, should we consider them for palliation if none of these options are there? So we used to have these meetings regularly, so that we know that where these VA ECMO patients are landing up, and if they're improving, if they need something else, or if they're on the transplant list, or if we should consider palliation for them. Of course, coronary angiography is a must for the patients whom we are considering might have ischemic etiology. Ventilation should be lung protective at all times, with tidal volume less than 6 ml per kg of idle body weight and plateau pressure less than 25. And once cardiac recovery occurs, it is essential to optimize ventilation also in order to prevent Harlequin syndrome. Dr. Saurabh has spoken a little bit about Harlequin syndrome already, so I'm going to just elaborate a little on that. So these are the daily checklist of patients who are on VA ECMO. We have to do all these things. Now, ventilation management, I already spoke about lung protective ventilation, and aim PCO2 above 2.5 kilopascals. And once cardiac recovery occurs, we have to optimize ventilation to prevent Harlequin syndrome. Anticoagulation management, I think Dr. Varghese had already spoken about. So just heparin and APTTR 1.5 to 2. And might be higher, we may need to keep it higher in case we are thinking that patient might develop cardiac thrombus or something, and fibrinogen more than 1.5. These are the aims for a non-bleeding patients. So this is the anticoagulation management. Now we'll go a little bit into what you expect and what things can go wrong when the patient is on VA ECMO. So this is a very common complication actually which occurs in patients of VA ECMO. That is LV distension that is occurring in patients if there is no cardiac ejection, and it will result in florid pulmonary edema and pulmonary hemorrhage. Now, let me explain to you a little bit what is happening here. So basically, VA ECMO, the blood flow rate is kind of high only. So you start with 1 liters per minute and then you increase it to 3 to 4 liters per minute or something. Now, when you do that, you're draining the blood from the systemic venous circulation. So because of that, the right ventricular preload decreases, the pulmonary, the peripheral venous congestion is decreasing. And we expect that the LV preload will also decrease and the pulmonary congestion will also decrease. But actually that doesn't happen. What happens is when you increase the ECMO blood flow, the blood pressure starts rising. Okay, and that is going to happen. So here in this figure, I've shown that when the ECMO blood flow is 1 liter per minute versus when the ECMO blood flow is increased to 4.75 liters per minute, the blood pressure actually starts rising. And what happens with that is actually that your aortic pressure will actually start, the right atrial pressure decreases with the increase in ECMO blood flow, but at the same time, your aortic pressure keeps increasing, the LV volume keeps increasing, the LV starts distending. But what is happening that the LV stroke volume keeps decreasing. So imagine the left side of the heart, the size is increasing, but the stroke volume keeps decreasing. So this, there is a lot of LV distension, and because of that, there'll be a lot of the florid pulmonary edema as well. So this is what actually happens when your ECMO blood flow keeps increasing, and there is inadequate LV venting, which can actually become catastrophic. And in this picture, as you can see, that as you're increasing the ECMO blood flow in this picture from 1 to 4.75, that your right atrial pressure keeps decreasing. As you can see this B figure, that the C1, that the right atrial pressure is nicely decreasing. But along with that, the aortic pressure keeps increasing and the LV volume keeps increasing. The LV stroke volume keeps decreasing. As a result of which, what will happen? The LV end diastolic pressure will increase, the LV end systolic pressure will increase, and the pulmonary artery pressure will increase, and the pulmonary congestion will also increase. Okay, and this will actually worsen your pre-existing pulmonary edema. Okay, so how do you detect it? So first you have to detect if there is a problem, and then you have to find a solution. So detecting is by echocardiography, you can directly visualize. So what will happen if your LV pressure keeps increasing, the duration for which the aortic valve is opening is reducing, right? So you can actually measure the extent and the duration of the aortic valve opening. And you can see that through M mode also, that will be helpful to see when the aortic valve is opening, how much it is opening, and what is the frequency of aortic valve opening. That is one way of finding out. The next thing is that you have a right radial arterial line. So keep taking ABG from that and see what is the PO2 of the blood that is exiting the LV. So if there is progressive hypoxia in the blood which is exiting the LV, which you can measure from the right radial arterial line, or if you have a cerebral oximetry, you can measure it through that also. That means that the perfusion of the superior circulation is, hampered, and the deoxygenation is happening because of worsening pulmonary edema. So that is one way of finding out. Other thing is, of course, it is a late finding, is that the chest X-ray is worsening because of the worsening pulmonary edema. Okay, and the worsening pulmonary capillary wedge pressure. Another thing is you can actually put a PA catheter to see what is the pulmonary capillary wedge pressure and find out also, which we didn't do very often. So this is a big problem. Now what to do? You have detected that the LV distension is happening. So there are some way of unloading the LV. The first is actually to reduce the ECMO blood flow, because the more the ECMO blood flow, the greater the LV loading, right? But there is a point to which you can reduce, because the whole point of putting the ECMO reduces if you keep reducing the ECMO blood flow. So, you can reduce it to some level, but after that, you have to keep adding some other support to help the LV. So either you can give some inotropes. So inotropes are simple to implement, obviously. You can start adding some inotrope, but, they are not going to help you that much. There's a limit to which it can cause LV unloading, and also at the same time, it increases the myocardial oxygen demand, which can be counterproductive. So inotropes can help to some extent. You can use vasodilators because they are going to reduce the systemic vascular resistance, and they're going to reduce your arterial pressure. With that, they're going to help the aortic valve to remain open for a longer period of time. With that, they're going to help the LV ejection and help in LV unloading to some extent. So some vasodilators you can use. Okay. Then you have IABP also. So IABP can also help in, reducing your blood pressure during the systole and helping your aortic valve to be open for a longer period of time and improving the LV ejection. Or you can probably do a arterial septostomy, which will actually help in left to right shunting. And this was one of the first, bedside techniques which was used. But I have never seen that happening actually. I have never experienced a balloon arterial septostomy. Or basically, there are other methods also. You can either put an LA to aortic cannula, or a surgical LV vent, or a percutaneous LV vent. So these are some LV unloading strategies which can be used during VA ECMO support if you think that the LV is becoming too much distended, and that's counterproductive for your stroke volume and cardiac output and everything else. So the next complication which you expect is limb ischemia. Now you're putting a big cannula into the femoral artery, so distal limb ischemia can occur, and that's why you have to put a backflow cannula. So to some extent, that backflow cannula is going to reduce the incidence of limb ischemia. And it's very important that post-decannulation reperfusion compartment syndrome has to be ruled out by thorough neurovascular monitoring following decannulation. This is also very important. Other things which can go wrong is, of course, bleeding. Bleeding, everybody has spoken about. I'm not going to talk about it again. Cryoprecipitate is the preferred, blood product to replace fibrinogen. Use Tranexa, obtain surgical review. Consider VA ECMO discontinuation, and consider late options like surgery and local tamponade and all that. Bleeding can be catastrophic, of course. Then other things which we can expect are the vascular complications like distal ischemia, vessel perforation with hemorrhage, arterial dissection, incorrect location, or development of pseudoaneurysm at the site of insertion. So these are the vascular complications which we expect. Now coming to the very interesting Harlequin syndrome. So Dr. Saurabh has spoken already a little bit about it. Very interesting. Now, what is happening? There are two blood flows which are happening in competition with each other, isn't it? So, the competitive blood flow happening in the aorta. One is the heart that is trying to pump the blood flow from the LV, and one is the ECMO blood flow. So, both of them are going to meet somewhere, isn't it? Now, the heart, the blood which is coming out of the heart is the deoxygenated blood. and the blood which is coming out from ECMO is obviously the oxygenated blood. So they are going to meet somewhere. So watershed area is what we have to know, where they're going to meet. Where is the watershed area? If the if the ECMO blood flow is better than the native heart, then they're going to meet somewhere distal, more proximal, which is better for all of us. But if the heart starts recovering and the LV starts pumping blood more vigorously, then the watershed can actually move distally, which is actually bad for all of us. Now, what will happen if the watershed area is distal to the aortic arc, then the dangerous complication of Harlequin syndrome happens, where there is cerebral hypoxia, and which can be definitely a deadly complication. So, which will lead to blue head, that is deoxygenated blood to the upper part of the body, and red legs, that is the hyperoxygenated blood to the lower part of the body. And how you can detect that? You can take an EBG from the right radial arterial line and see if this is happening. This is again very, very dangerous, and we have to act immediately. So to prevent this from happening. So how do you fix it? You increase the PEEP, you increase the FiO2, try to optimize the ventilatory settings. If you still need ECMO support, you might want to think about central cannulation. I know that's not a very favorable option. Then axillary or carotid. If the heart is recovered, then decannulate the patient. This is one scenario where you actually consider putting the patient on VV ECMO, or in some cases you might think of Impella as an alternative support, but I have never used that. I definitely have converted VA to VV ECMO because of Harlequin. So after that, we'll move to the next problem that can occur with VA ECMO. Of course, heart not moving. What will happen? You expect stasis of blood to happen. LV is distended, so thrombus, very unfortunate if it happens. How do you actually detect it? Frequently, you have to do a transthoracic echo and have a high index of suspicion to detect it. Very unfortunate if it happens. LV thrombus. Now we'll go to the weaning of VA ECMO. Again, MDTs is the key to wean from VA ECMO. Keep talking to your consultant, keep talking to the cardiologist, to cardiothoracic surgery. Progress should be monitored. Consider possible potential outcomes. Is the patient recovering? Do you need a ventricular assist device, or is the patient a candidate for transplant? Or maybe, nothing is working, then definitely palliation. So as the underlying disease process improves, the cardiac output will improve and the competitive flow will also develop. So, we have to be very, very, very careful while weaning the patient. Readiness for weaning can actually be indicated by improved pulsatility of the aortic waveform and implementing either TOE or transthoracic echo and seeing how much is the aortic VTI, and improve cardiac output with a reduction of the ECMO blood flow. So this was our usual protocol. This is how we did it. So if you see there's a clinical indication, evidence of recovery, your vasopressors and inotrope requirements are coming down, and you're doing a TOE or a transthoracic echo daily and seeing that the LV-RV function is actually improving. Reduce ECMO support, reduce the ECMO blood flow. If it was 4, reduce it to half. If it was 4.5, reduce it to 2 or something, and then reassess the vitals and hemodynamic parameters. Continue weaning if the stable hemodynamic parameters are there, and you're able to maintain the same inotrope and vasopressor requirement, and LV and RV look okay on TT and TOE. And continue doing this. Now reduce the ECMO flow then to 1 liter per minute, and then again reassess the patient. See ejection fraction, see the pulse pressure, see the RV function if it's adequate on transthoracic echo. See the respiratory function also. And there is no shock, the lactate levels are under control. If all these parameters are satisfied, then weaning is complete. Consider for decannulation. Now, decannulation is not very simple in VA ECMO. Unfortunately, you have to involve the vascular surgeon. You can't do everything. They need to know because they need to remove the arterial cannula and repair the artery. That has to be done in the theater, not in the ICU. Clamp the circuit at the access and return cannula. The venous can be removed as we do it in ICU, sutures and all that. But for arterial, you have to shift. So, we do the VA decannulation in theaters and duplex ultrasound of the lower limbs to exclude DVT and reassess for any aneurysm or pseudoaneurysm after 24 to 72 hours post decannulation.